Okay, good morning. Boy, I can feel the buzz in the room. This is a very exciting Grand Rounds. All right, we're going to go ahead and get started. So as always, I want to call your attention to the upcoming Grand Rounds. It's really such a nice spectrum of research, clinical, and really cutting edge research. So I'm really proud to see how the Grand Rounds Committee, thank you, Matt, is doing such a nice job. And we always like to promote some of the other things we're doing. This is the, MCC POP, 40th annual, perinatal potpourri. Okay, good. For a minute, I didn't know what the abbreviation was. Good. And then almost every month, you're going to hear about the Engage lecture, healthy work environments through crucial conversations, and curriculum development and measuring outcomes. So please save the date. All right, it's such a great pleasure to introduce Anisha. I've been talking about this particular Grand Rounds all month, and today's the day. We're so lucky to have recruited Anisha here a couple years ago. So she's an associate professor in the Division of General Pediatrics here, and she's also an affiliate at the Institute for Health Policy Studies at UCSF, which is a really great partnership. She practices general peds at Gardner Clinic, and her research focuses on child health promotion, including healthy children grow up at a healthy weight. She is just the perfect example of community-based participatory research. And actually, I've used her work as an example when I met with the C-suite to talk about how we have to provide laboratory translators and labs in the evenings and in the weekends when our community really needs access to that in terms of being able to enroll in our studies. So she's conducted numerous studies to evaluate interventions and policies to help children and families reduce daily sugar intake, particularly from sugary drinks, published extensively in this area, NIH funded, and then MCHRI was very proud to award her one of our coveted faculty scholar endowments, and because our mission in MCHRI really extends all the way through the policy end of the spectrum. And everybody was so pleased that you applied for that, and we were able to award that to you. I don't want to steal her thunder in any way, but I think her work has already had policy impact. She's been recognized for this work with awards from the American Academy of Pediatrics and other places. And so with that, Anisha, give you the floor. Welcome.
So I don't know if I picked a good day to talk about reducing sugar since it's Valentine's Day, but maybe half the sugar. Actually, someone has a book that I just came out with, Half the Sugar, All the Love. So it's just less sugar, not no sugar. All right, so during the presentation today, I'm going to first summarize some expert recommendations for beverage intake for 0 to 5-year-olds, because I know there are a lot of clinical folks in the audience, and hopefully this will help you out in practice. I'll also discuss the importance of childcare facilities as a setting for shaping children's nutrition habits. I'll then go on to describe some programs and policies to promote healthy beverage intake in childcare, including an intervention we conducted in San Mateo County. And then lastly, I'll help you leave you with some educational resources you can use at home with your kids or in your clinical practice. So first, I wanted to take a moment just to talk about a project I worked on and I presented the last time I was here at Grand Rounds. And I know a lot of you probably remember this story, but I was a resident now almost 15 years ago, which is quite some time ago. So I was in a lot of the same shoes that many of you are here who are trainees. And I was in the inaugural classes of the Stanford Advocacy Track that Lisa Chamberlain and Janine Bruce are leading. And as a part of that program, the community rotation, the residents went out to East San Jose in the Mayfair neighborhood and actually were conducting some listening sessions with the families to understand what some top priorities were for child health promotion. And during those listening sessions, childhood obesity came up, mainly because a lot of the elderly individuals in that community were realizing that diabetes was a big concern, as was heart disease, high cholesterol, hypertension. And so they really wanted to do something to prevent this for the next generation of children. And so I decided, okay, this is a great topic. I didn't really come in necessarily in residency with an interest in obesity per se, but I was interested in community-based research and really working with families in the community to address health problems. And so we worked with an elementary school and decided to set up some classes for the students where we would teach physical activity and nutrition to families and the students. And we even brought some props to try to get them physically active and set up like some events where they were like almost like a field day type experience at the schools. And through those experiences, heard from the families that actually they didn't have safe green spaces in that area to actually be physically active. And soccer was a very important sports activity for those families, which were largely Latino. And so they really wanted to do something about that. Behind this elementary school where we were working, there was actually this huge grassy field, but it had these holes in the field. And so it wasn't really usable. The kids would trip and fall, or it was pretty unsafe. And there were gophers well, maybe not gophers at the time, hopefully not, but there were gophers at some point in time in those fields. And so we decided to work with the families to try to raise funds or to advocate for resources to revamp that field because it really wasn't being used. And so when I left residency, they were constructing the field and it was a safe place for the kids to play, but also they opened it up to community members as well. So that's an example of, you know, when you partner with communities, listen to what they want, what kinds of impact you can have. And so I left that really energized, you know, after residency, really wanted to kind of learn more about how to evaluate programs like this and how to do research in this specific area. And so then I applied for a fellowship. It was called the Robert Wood Johnson Clinical Scholars Program. It doesn't exist in the same format currently, but it is now taken over by a name. It's called the National Clinical Scholars Program. And there are several sites in the area if you want to look into those types of fellowships. But the goal of the fellowship at that time was to learn more about community-based participatory research. So how do you partner with communities to develop the research question that you want to address, and then actually implement the research with those community members. And so Mark Schuster, I know, is on the list of folks he's gonna be talking later this month, and he was actually my mentor for this fellowship program, where I went down. He had received a grant from NIH to actually conduct a program in partnership with communities to develop an obesity prevention program in middle schools. And so my fellowship program was really to go out there and observe what the children were eating and drinking in the schools and also their physical activity levels, and then use that information to help design the intervention in conjunction with community members. And so when we were out there at lunch one day observing, some students came up to us and said, it was a hot day in LA sometime in August. They said, you know, we really want to have water with our lunch. And, you know, I had remembered lunch programs from when I was a kid in North Carolina, but hadn't really been to many California schools in terms of observing their lunch, and noticed that they really did not have access to water with the meal tray. There was chocolate milk and juice. If they wanted water, they had to step outside and go to a dilapidated fountain that was pretty non-functional. And so we decided as a part of this intervention, we really wanted to address healthy beverages. So LA had done a great job of removing some of the unhealthy drinks, so no sodas were allowed, but they hadn't really thought about healthy alternatives. And so that's why I started this focus on working on beverages. Again, students told us what they wanted us to address, and so I started on this topic. So why are beverages important? They are the largest source of added sugar in the diet. As you can see in this pie graph, about 50% of added sugar that we're consuming today actually comes from beverages, and sugar-sweetened beverages in particular. We know that a quarter of actually the dietary intake from sugar actually comes from what we call hidden sugars, which are foods and beverages that are seemingly healthy. So even things like, you know, condiments or a salad dressing, you know, you're trying to have a healthy salad and then you realize that the salad dressing has a ton of sugar and added sugar. Or soups are another example. And so this is where the contribution is. But beverages, you really can have a big bang for your buck, so to speak, if you really address that, since 50% of sugar is coming from that source. So what is added sugar? How many of you, I feel like added sugar is out in the news. How many of you actually have heard of added sugar or know what it means? For the most part, most people. So added sugar is when you're basically adding sugar to a product. So it's not the intrinsic sugar that's present. So like, let's say you're eating an orange, that does have sugar in it, but it also is accompanied by fiber. So, but if you take, you know, the orange or some apples or some berries and add some sugar to it, that would be adding sugar. In your coffee, if you add sugar, that's added sugar. Or at the processing phase, a lot of industries actually add sugar to products, especially if they're sourcing ingredients that may not be in season. So an example is, you know, if they're preparing a tomato soup with tomatoes that aren't in season, you know how the tomatoes taste when they're not in season. They're not really sweet in the same way that the ones in the summer are. And so a lot of times they have to add sugar. The other reason they add sugar is because it is also a preservative. So I don't know if you all have noticed, it helps with browning. It's also a browning agent in terms of baking. So there's a number of reasons why we do have a lot of sugar in our diet currently. So added sugar is important for health, especially if we consume it in excessive amounts. Many of you probably already know this as well, but added sugar can lead to increased intake of calories, which can contribute to obesity and related comorbidities such as diabetes, abnormal cholesterol levels, heart disease, fatty liver disease. Also, there's emerging data looking at the addictive properties of added sugar. Dental caries are also a major concern in our clinical setting. So a number of health concerns related to added sugar consumption. So for this reason, the American Heart Association and other groups have actually set guidelines for added sugar intake. And in this slide, I've tried to I was making this in clinic. Ryan saw me. He said I should point him out where he is in this slide. He said he's one of the 14 to 18-year-old men, not the older guy. So up to 2-year-olds can have no added sugar actually in their diet. That's the recommendation. And the reason for that is they're forming their dietary preferences. And so the recommendation is really to try to avoid added sugars for those younger kids. 3 to 8-year-olds, they can have up to 3 teaspoons per day. 9 to 13-year-olds, the recommended amount is 4.5 teaspoons per day. Adolescents who are between the ages of 14 to 18 are 6 teaspoons per day, as well as women, and then men is up to 9 teaspoons per day. So it's really confusing trying to figure out how much added sugar is in products, especially if you're not actually making the product or, physically baking or cooking at home. And so there used to be a nutrition label, and in that nutrition label, there would be a sugars line item, and it would just say sugars, and it was any sugars that were in the product. So to give you an example, like if you purchase a vanilla yogurt that's sweetened at the supermarket, it has lactose in it, which is a natural sugar that's present in milk, but it also has sucrose, which is like table sugar that gets added to the yogurt to make it sweet. And so when you look at that sugars label on the label, it'll be both the lactose and the sucrose, so you don't know how much is coming from which source. Now there's a new nutrition label that just got finally released. It's been a while, it was delayed a bit, but the FDA approved it. And so now when you look at packages, you should be able to see this line item for added sugars as well. So that'll tell you exactly how much of the total sugars is coming from added sugars. But then again, it's still confusing because here in the US, we don't really understand grams that much. So we have to take the grams and then divide to get teaspoons, because that's what most of the recommendations are in. So the rough guide is about 4 grams is equal to 1 teaspoon. But again, you could see a lot of our families don't have the health literacy to go through this and to understand like how to calculate all this from the package. The other issue specific to beverages is there's a lot of marketing happening that is really confusing for families as well. So you could see up at the top a drinkable yogurt, for example. Apart from the monkey, there's also all these fruits on there. So it looks like it's a healthy choice because you see there's fruit, and a lot of times it'll say that it has fruit in it. You'll have products that say that they're organic, again, trying to kind of, get parents excited about purchasing those products. These toddler formulas are actually emerging. There's a lot of marketing happening, especially for immigrant populations that are coming here from other countries. In their home countries, they may have used these products because, there was lack of food, they needed additional nutrition. But here in the US, these are not indicated, and you will see a lot of families are actually utilizing these toddler milks. So this is a milk that when you're, turning 1, usually we transition children from breast milk or formula to just cow's milk or some alternative. And so this is what is being marketed as the next step rather than going to cow's milk. So why infants and children? You all are pediatricians, so it's probably clear why this is important, but we know that young children are consuming 3 times the added sugar limit per day, so about 18 teaspoons per day of added sugar is being consumed by children here in the United States. We also know that patterns that are set in childhood influence behavior in adulthood, and so it is really important to really train the palate early so that children are more accepting of beverages and foods that are less sweet. So now I'm going to move on to talk about these new beverage guidelines. So these came out in October. How many of you have actually heard of these or seen these? A few of you. Okay, so I'm going to go through all of them so you can utilize this in your clinical practice. The website is really great. It's very user-friendly. There's great handouts in multiple languages, Spanish, English, and Tagalog. There's also videos for families as well that you can utilize if you're trying to counsel families on this topic. But the reason these guidelines came about was healthy eating research. They're basically funded by the Robert Wood Johnson Foundation. They were interested in really trying to understand why families are confused about all the beverages. And what we found was, like, you know, when you go to WIC clinic, you might hear one thing, you go to your pediatrician, you hear something else, dietitian might tell you something different. So the goal was really to try to get all these groups together so that you could have consistent guidelines across all the organizations. So the dentist groups came together, American Academy of Pediatrics, the Academy of Nutrition and Dietetics, and the American Heart Association. So for the guidelines, I'm first going to start with sugar sweetened beverages. So I've talked a lot about added sugar. So sugar sweetened beverages are basically beverages that have added sugar in them. And they are not recommended for 0 to 5-year-olds. And the reason is because children are, you know, developing their dietary preferences pretty early. And so it's important to try to keep these beverages out of their diet. They also have very minimal nutritional value. Flavored milk is not actually considered a sugar sweetened beverage in a lot of venues. So like, for example, the soda taxes that are getting implemented now, they don't consider flavored milk to be under that category. And the reason is because they do have some nutritional value. It's a source of vitamin D, protein, and calcium. Milk intake can also promote bone health and growth. And we know that actually if you flavor the milk with chocolate or strawberry, kids do drink more milk. However, this leads to increased intake of added sugar and calories as well. We conducted a systematic review a few years ago and found that the impact on weight gain is unclear because there are just limited studies in this area that are high quality. So for this reason, the recommendations state that children 0 to 5 years of age should not have flavored milk. 100% fruit juice is also kind of controversial. Juice does have nutrients, but it has little fiber compared to whole fruit. It's also a source of calories, and it's considered a gateway drink. There's actually a study done, not to like alcohol, but to sugar sweetened beverages. So there was a study conducted, I think like 3 or 4 years ago now, by Elsie Taveras' group up in Boston, and they have a cohort that they're following. I think it's called Project Viva. And it's mostly Latino infants that they were following. And so what they did was they asked them questions about, you know, what kinds of beverages they were consuming in infancy. And those infants that actually were consuming the juice were more likely to consume sugar sweetened beverages later in life, also juice, and to be overweight. And so their article actually calls juice a gateway drink. There was also a systematic review, a meta-analysis that was conducted a few years ago that found that there was a small amount of weight gain among 1 to 6-year-olds who consume juice. And then there's also the concerns about dental caries, particularly if children are walking around with juice in sippy cups or bottles all day. So 100% fruit juice recommendation. So if children are less than 1, it's not recommended. After 1, it is recommended, but you know, only in minimal amounts. So up to 4 to 6 ounces per day, depending on the age. The recommendations do, however, suggest whole fruit is preferred over juice. However, it's understandable that there are some families out there that can't meet their fruit requirement just from fruit, and so there may be circumstances where juice is needed to meet those requirements. So water is what I focus on a lot. So I like to provide healthy alternatives to families, so we're not just telling them, you know, cut out all the fun and you have nothing good left to drink. But water is important because if you're drinking water instead of sugar sweetened beverages or juices, it could lead to obesity prevention, help to prevent dental caries, and also there are some studies suggesting that can help to promote cognitive function. About 1 in 2 children in the U.S. are inadequately hydrated. They've done some studies where they've actually checked children's urine osmolality when they come to school and found that they are not adequately hydrated when they come to school. And a lot of teachers we work with in schools actually tell us anecdotally that they give the kids water, especially on school testing days. So water recommendations for 0 to 6-month-old children, no supplemental water is recommended because those children, you know, those infants should be getting the majority of their nutrition from either breast milk or formula. However, after 6 months of age, they do recommend that you can give up to 1 cup of water, typically at meals. And the reason for this is just to get them used to the taste of water, to help them developmentally to be able to learn how to use a cup. And they would prefer you to give water than juice. And then between the ages of 1 to 5 years, you can have water throughout the day, upwards of 5 cups. And it really depends on where you're getting other sources of liquid from, because you can get water from fruits and vegetables, other foods, as well as other beverages. With regard to water, the other recommendations is that infants and children are drinking water that's actually fluoridated. And the reason for that is it helps strengthen teeth to prevent dental caries. They also recommend avoiding or limiting carbonated water as well, and then making sure that the water that children are drinking is actually safe. And so, when we're talking about water, you have a couple choices. You could either have the bottled water or the tap water. We know from work that we've done and that others have done that nationally in the US, minority children and children from low-income backgrounds are much more likely to purchase bottled water. And, those are the families that really don't have the resources for that. And so it's important to think about that in the clinical setting. Why is that happening? It may be that their water is unsafe. There may be misperceptions from when they, immigrated to this country from other countries that the water wasn't safe to drink. Tap water does have a number of benefits as compared to bottled water. It has a limited environmental impact because you're not using all those single-use bottles. Also, it's typically fluoridated in most places. So most of the bottled water on the market is not fluoridated unless it specifically says so on the bottle. The other reason to drink water from the tap is that it's usually just less costly. So what about water safety? So here in this area, we're super lucky. There are some places in California that actually do not have safe drinking water. They have arsenic or nitrate contamination, for example, in the Central Valley. We've done some work in those areas where children actually do not have water to drink in schools that's safe, which is kind of crazy here in the US. But here in this area, we're really lucky. We have great tasting water from Hetch Hetchy. The water comes to us from a public utility where it's tested. However, lead can enter the water if you have older building with older pipes. It can also enter through lead service lines, which really aren't that common here in California, but in other parts of the country they are present. So if you have an older home, lead can actually get into the drinking water, even though it's safe when it comes out of the public water utility. And so what can we do for families with regard to lead? I think Flint really highlighted the importance of lead and lead contamination and impacts on health for children. So if you're interested, or if you have families that are interested in testing their water at their home for lead, there's actually the California Water Boards has a great website that you can go to. And the website, you can actually type in whatever city you're in. So I was at Gardner, so I typed in Atherton. And then you find all the labs will pop up on a map and you can click on one. And typically the lab testing costs between $25 to $40. It's pretty easy. We do it with our schoolwork. Where they send you the testing kits. You take the sample, usually it's first thing in the morning after the waters sit all night because the water has the highest levels of lead in the morning. And then you just either mail it back to the lab, or sometimes they'll even come pick it up from your home, and then they'll give you the results like within a week. And it's a pretty easy process. Jeff actually works on our team. He does it a lot. We do it in schools quite a bit. So it is costly for families, $25 to $40. However, if you look at the long-term impacts in terms of cost savings from bottled water, potentially it could be a good option. The other thing I wanted to mention are there some locations where lead testing is actually free for families who are eligible for WIC. So in San Francisco, for example, if you're a San Francisco resident and you're eligible for WIC, you can get free testing through the San Francisco Public Utilities Commission. New York has a similar program as well. So the plain milk recommendations have not changed. They are exactly the same as they have been. So 0 to 12 months, it's formula and breastfeeding. And then 12 months, you switch over to cow's milk, usually whole milk, and then you transition over to skim or 1% when the child is 2. This is an area where I think there may be changes in the future because there are studies coming out suggesting that actually whole milk, drinking whole milk may be beneficial in terms of weight gain for children. And it's unclear what the mechanism is. It may be related to the fact that whole milk is more satiating than skim milk, and so you're less likely to eat some of these other foods. So like instead of eating 4 cookies, maybe you have 2 with a glass of milk. The other hypothesis for this too is that perhaps individuals who are drinking more whole milk just have a better overall diet quality. So plant-based milk, so these are really emerging as well. So oat milk, soy milk, almond milk. So these are actually not recommended in place of dairy unless there's a medical indication or a strict dietary preference. And the reason for this is a lot of these other milks don't have the same nutritional profile as cow's milk. The only one that comes close is actually soy milk. So it's really important if you have families that you actually look at the nutrient profile of all these milks and make sure that they're getting enough fat and other vitamins, calcium, etc. The toddler milks I did already bring up. Toddler milks are definitely not recommended, and I urge you all to ask your families about whether they are using toddler milks because they are very expensive and a lot of times they have added sugar. If they're being imported from other countries directly here, they may also not be FDA approved. Beverages with low-calorie sweeteners, even stevia, are also not recommended. They can be up to 20,000 times as sweet as table sugar. And so if our goal is to get children to not, want to have all these sweet foods and beverages, it's really not going to help. There's also a lack of long-term data on the health impacts of these low-calorie sweeteners. All right, so now that I've kind of gone over all the beverage guidelines, I want to shift a little bit to talk about some of our work in childcare settings. So childcare is a key setting for promoting healthy beverage intake. There are about 12.5 million children in the US that actually attend childcare each day. Important setting also for not only reaching the children, but also childcare providers and their families. And we know that the preschool age children are drinking quite a bit of calories from these beverages, 60 calories from sugar sweetened beverages and 53 calories from juice. And we also know that it just takes a small reduction in calories to revert us back to levels of obesity of like 20 years ago. It's estimated for this age group about 23 calories is only needed. So you can make a big adjustment just from the beverages. So in California, there's a lot of momentum related to healthy beverages in childcare settings. In 2012, there was a law that passed called the Healthy Beverages in Childcare Law, AB 2084. And this basically stated that all these guidelines I've been mentioning, that childcare facilities really need to implement those. And so the goal was to make sure that water was accessible at all times, that low-fat, unflavored milk was only provided, so no flavored milks, 100% fruit juice was allowable, 1 serving per day, and no sugar-sweetened beverages. There was also a law that just recently passed that requires childcare facilities to test drinking water for lead, and so that those are the licensed California childcare facilities, and they have to do that by January 2021. So we've done some work in childcare where we've gone in and observed to see what the implementation of these laws look like. Our colleagues are working on a study that's actually in press where they went back and actually in 2016 surveyed about 5 years after these laws were implemented to look at implementation, and they found that only about 50% were actually fully implementing these laws. When we've gone to observe too, we found that water wasn't readily available. A lot of times these childcare facilities would have a sink, but they really wouldn't make water accessible to the children throughout the day. So our goal then with this project was to really develop an intervention to implement these healthy beverage guidelines in childcare, and to also educate childcare providers and families about the importance of healthy beverage intake. So we set up a community advisory board in San Mateo County, and that community advisory board consisted of partners in the county, including the Department of Public Health. We also had the 4Cs, which is the resource and referral agency for the county, Parks and Recreation. The school district was involved as well because they actually oversee a lot of childcare facilities in the county. And we came together with those folks as well as childcare providers and parents and talked about what would be priorities for this intervention. We also conducted formative research to develop the intervention where we went out and actually interviewed parents as well as childcare providers to ask them what were barriers to implementing these guidelines. We also conducted observations in the childcare facilities to see, what could be feasible. And then we put that all together and conducted a pilot randomized control trial in 4 centers. So we randomized 2 to receive the intervention and 2 to be controls. So what was the intervention? So first we wanted to focus on policy implementation. So we actually worked with the childcare facilities to try to figure out, did they have something written for the parents, like a handbook or some other type of policy? And if they did, we looked at it to see if it was consistent with the California law, and if not, we would, revise the language. We also tried to push them a little further, so we asked them if they could to try to provide whole fruit instead of juice, and also to restrict sugar sweet beverages for like family events and parties, because law really doesn't say anything about that. We also worked with families and childcare providers to set up kind of rules for their own home environments. So we asked them we had a list of all these different options they could select from on a little contract, and they could select what they felt was doable for themselves and their family. We also wanted to make sure we made the environment more receptive to these healthy choices. And so we tested the water in the childcare facilities for lead, and then if there was a problem, we remediated it. We also made sure that water was available for self-serve throughout the day. So we provided every child with a BPA-free reusable water bottle. Thanks to the Community Advisory Board, we came up with the idea of actually taking every child's picture, and we made some waterproof stickers and stuck them on the water bottle so that the kids could find their own. So we didn't end up with like more infections in the childcare facilities. We also sent water bottles home to children as well, and then gave them to childcare providers so they could model healthy drinking behaviors, because we know from our school-based studies that if teachers are drinking water, the children are more likely to drink water. And then we also provided the childcare facilities with pitchers and cups so that they could make sure that water was available at meal times, because that's actually a big barrier. A lot of childcare providers are worried that if children have water at mealtime, they won't drink milk or they won't eat their other foods. And lastly, we implemented educational activities that were directed towards children, families, and childcare providers. So there's a book, Potter the Otter, A Tale About Water. Does anybody know about that book? It's developed from First Five, Santa Clara County. They actually have several books, including some on fruits and vegetables. I think they have one on oral health, so you can go online and check them out. They're available in multiple languages and only cost $1 per book, so it's a great educational tool. So we did distribute those books to all the families. We also worked with childcare providers to have them read the books twice a month. And then we worked with Andy Z, who's a local singer-songwriter. He made a song for us called Drink More Water. And it has some like dance moves. Jeff knows because we work with the kids in our elementary school project as well, and they all get up and they do all the dance moves. It's very cute. So the child care providers actually worked with the children to sing the song and implement the hand gestures, get some physical activity as well. We also held training sessions for the parents where we talked about the importance of healthy beverages, how much sugar's in different drinks. Signage went up in the facilities, and then we had brochures. And the last piece was we used data we collected at baseline. So we asked all the parents about what their kids were drinking. And then we also measured their height and weight, and we wanted to give that back to the community. So we made each child their own report. And so this is, I don't know if you could see it that well, but I can kind of give you the gist of the report. So this report is modeled off of a report card that Chris Madsen, she's a pediatrician who works up at UC Berkeley now. She was up at UCSF before, but she had an R01 funded study where she was working with the state of California Department of Education to revamp their reports, because currently in California, it's mandated that in 5th, 7th, and 9th grade that all the children have their BMIs measured in school. And families receive a report card, but it's oftentimes really hard to understand, doesn't really make a lot of sense. So we revised the report to look like the one you see up there. So if you're in the green zone, you're fine. The red zone at both ends is unhealthy weight, and yellow was at risk for overweight. And then we also provided some information about how they could improve their beverage consumption patterns. So our outcomes for this study were to examine the impact on children's beverage intake at home, which we measured through validated parent questionnaires. We asked about different types of beverages they were consuming over the course of a week. We also asked them about less healthy beverages, in particular, including sugar-sweet beverages, flavored milk, juice, and high-fat milk, so 2% and whole milk. And then we asked about healthy beverages, low-fat milk, and water, and we aggregated those into those two categories because our goal was to promote healthy beverage consumption and discourage less healthy beverage consumption. We also monitored children's weight status through height and weight measurements and wanted to look at the proportion of children who are overweight or obese in these centers and how that changed over time. So this is a slide that shows you the characteristics of the children and family in these childcare centers. So we had 2 intervention centers, 2 controls. This was definitely a pilot study. So you can see that between 39 to 43% of the children were already overweight at that age, which I think echoes a lot of the demographics we see in the clinical setting as well. Most of these families were Latino, and a lot of them, had low education levels and very low household income. So now I move on to the results. In this slide, you can see the intervention impact on daily intake of less healthy beverages. So in the red is the change in the intervention group, and the blue is the change in the control group. And so what this shows is the change over time from pre to post in both of those groups. And so in the intervention group, for example, the children reduced their consumption of less healthy beverages by 2.3 ounces per day. In the control group, they increased their consumption by 3.6 ounces per day. So the net difference between the groups, or the result of the intervention, was actually a reduction of 5.9 ounces per day. So with regard to impact on healthy beverages, again, the slides are set up the same. So we have the red is the intervention group, the blue is the control group. So you can see that in the intervention group, the children increased their intake of healthy beverages by 5 ounces per day, and the control group by 1.5 ounces, for a net impact of increase in 3.5 ounces. Intervention impact on weight status. Again, we're not really powered to detect changes in this, but we did see positive trends. So this shows you the change in the percentage of children in the facilities that were in the overweight categories. You can see that in the intervention group went down by 3%, and the control group went up by 3%, for overall impact of -6. So in summary, we found, based on this pilot, that this healthy beverage intervention showed promise in promoting healthier beverage intake, discouraging consumption of these less healthy beverages, and led to a positive trend in reducing obesity. So we plan to hopefully implement this on a larger scale in a trial that has a longer time frame as well, because this was just 6 months. Okay, so now I'm going to move on to some educational resources, and I like to show this slide. Larry Green actually is a mentor of mine on many projects, and he actually developed some theoretical models that you may have heard of. And so he has an article that talks about the concept of dissemination to evidence-based practice and how long it takes for information to get out there in the world. So, from the time that NIH or RWJ, sets a priority for funding to the time that you apply for a grant, you don't hear for like 2 years, or it doesn't get, funded because you have to resubmit it. And then you do the work, and then you publish it, and then hopefully eventually it'll get out there into practice. So that process takes about 17 years, which is crazy. Hopefully now with social media and everyone's, I feel like, is trying to disseminate things a lot quickly, hopefully this will be reduced. But I think by working with community partners, you can actually get the information out there much more quickly. So I'd like to give you some examples of some kind of more practical tools that we've developed along the way, and how we go about making sure they're disseminated. So usually what we do, instead of, like, when we're developing an intervention study and we have a protocol for intervention, instead of waiting till the very end to disseminate the information, we usually just put it up on our website and try to get it out to partners right away. I know it hasn't been fully implemented, but we feel like, we have the resource available. We've dedicated a lot of funding to that, so we may as well make it available to the public. So this is an example of a product that we're using right now in a school-based study that's very similar to the childcare one I presented. And we show this video to the kids in the classroom, and then they also get a copy to take home with their parents, and they utilize it to talk to their families about the importance of healthy beverages and come up with some ideas for what they can change at home. And this video actually came about because in our childcare study, when we had these training sessions for the families where we talked about added sugar, a lot of families couldn't attend because they were busy working multiple jobs, and so they asked us to develop a video instead. So this is a good example of a product that really was informed by community members. The Andy Z song that I mentioned as well, we also implement that in our school-based projects. So you guys should take a look. You'll be singing it all day. But it is utilized in our school project, and then we also utilize it in the childcare project, and many, many individuals across the country are using it in their own work. We also put together how-to toolkits. So this is an example of one of the toolkits we developed for the Central Valley. We worked on a project where we tried to get safe water bottle filling stations in areas that did not have safe drinking water. And we wanted to give the community sites a resource that they could use to promote water in their own local communities using their own kind of resources and ideas. So we put together a list of all the different promotional campaigns that we had come across, and they're all kind of set up by setting. So like we have the clinical setting, childcare, schools, et cetera. So you can go through and find options that work for you. So this is another example of something that's very practical. Recipes have come up as well. So Jennifer Tyler Lee, I've worked on a cookbook with her, and our initial project together was actually to develop a short video clip that gives families some ideas of how they can flavor water with fruits or vegetables rather than adding sugar. And it's great because it doesn't have any words, so it's accessible to any language or literacy level, and it's very short and easy. And we also utilize that in some of our school-based interventions. Kids actually make a recipe card with their own ingredients and bring it back, but this is also widely available. The storybook, as I mentioned, was not developed by us. It was developed by First Five Santa Clara County, but we are actually in the process of evaluating it with them. We're doing some online testing to see how parents respond to this book versus other books that we've kind of tweaked a bit to promote healthy beverages versus discourage healthy beverages. So what can you do in your own clinical practice or the work that you all are doing? So I think the first is just, bringing up the topic with families, because I do think it's a small, easy, concrete step change that families can make that could make a huge impact in terms of beverages. The toddler milk, I think, is a really easy one that oftentimes we don't ask about. So when the children, the infants are, approaching year one, just ask them if they are thinking about toddler milks and maybe talking about how they're not indicated and costly. Also help families and children set very small concrete goals and check in on them pretty frequently to see how they're progressing and, equip them with resources so they feel empowered to make the changes rather than telling them, don't do this. Give them some tools to help them make the healthier choice. Providing educational resources, as I mentioned, including the healthy Kids Healthy Drinks website is really great. You can use it in clinical settings. And then lastly, advocacy for policy change is super important as well. And these are some groups that actually do a lot of great work in the nutrition space. So if you follow them on Twitter or other social media, you can sign up on their listserv. They put out action alerts a lot of times where you can easily submit a comment or just click to sign on to a letter. So this is an example of an action that's happening now. There's many of them because Trump is rolling back all the meal plans and everything. So there's a lot of work to be done, but this is one concrete example of something that we're working on right now. So the Dietary Guidelines for American comes up for renewal. It's basically every 5 years. And so the comment period is coming up in May. And you can submit comments now for a number of topics. But one that we've been working on is getting water on MyPlate, because MyPlate is like the public-facing Dietary Guidelines for Americans. It basically takes the information and puts it out there in a picture so people can understand what they should be consuming. Currently in the US, we have dairy on there. Surprise, surprise, but there's no water. And Canada, I put Canada's up here. I like Canada's plate because it's really colorful. It really shows you how to be plant forward, but also like if you're eating protein, how it doesn't have to just be beef or, pork. It could be also other varieties of protein rich foods. And then there's whole grains and there's water. There's not even milk on there, MyPlate. So I think this is a good example. You can easily go to this website, the Drinking Water Alliance I work with closely and I'm a member of, so you can just submit a comment pretty easily. So I'd like to thank everyone who's been involved because it really does. Jeff, who's back there, who's going to be going to medical school next year too, he knows it takes a whole village to do this work. We're working with the schools, we're working with all the community-based organizations, all the collaborators, the advocacy groups, everyone. So it takes everybody to do this type of work. So I'd like to thank you all for listening, and I will answer any questions.
Fantastic talk, and of course on the front line of obesity and type 2 diabetes were there. I actually have 3 very trivial questions. The first one was, I hear a lot from Latinos families, well, we make the fruit juice at home and I really don't know what's in it. So that's number one. Number two, I worry about Pediasure, not in kids who really need it for we build it up, people think it's extra healthy and it's flavored. And the third is, I hear from families, my child is not allowed to go to the bathroom, and therefore they're not going to be in school. So those are barriers that I see. Can you comment?
Yes, so the first question is related to folks making concoctions at home in terms of healthy beverages or not healthy beverages. So specifically Latino families may be making fruit flavored juices at home, and it's unclear what they're putting in it. So I think you just have to get more information, and in clinical settings, we don't have a ton of time. So if there is ability to work with the dietitian or nutritionist to help, that would be great. But just asking them, are they adding like sugar to that, beverage? Because I think a lot of families, sometimes they may not be, and a little education goes a long way there. And you could always provide them with the fruit water video, because we try to kind of bring that up in pictures and videos. The other question was about these toddler milks, Pediasure. A lot of families are using them even though they're not indicated, and they also have a lot of added sugar. So I agree. There's actually a report that just came out a couple weeks ago from the Rudd Center group that basically is showing that there is targeted marketing of these formulas to families, specifically Latino families. And so I think it's extremely important that we get the word out and really ask about it in our clinical practice. Like when we see families that actually are transitioning over to solids, just bring it up in your conversation, because there is this true marketing. People think that they need it for growth and that it's going to help their child be smart and do better in school and all these other things. So I do agree with you on that. And then the last question was about drinking water and how you promote water when they can't use the bathroom. That has come up as possible barriers, but in our school-based study, now we've been in 26 schools, we haven't found that has come up as much. We are in low-income schools, but we are in elementary schools. So it may be, in middle schools or high schools, some children may be scared to go to the bathroom too because of bullying or other things that happen in bathrooms. So it is a true barrier. I know a lot of children don't drink at school because they don't want to use the restroom. So, and I don't know, it's a larger problem. So, thanks for those questions. Yes.
Thanks, Anisha. That was really a wonderful presentation. A question about what pediatricians do in the office or clinic with patients. In promoting, particularly that slide, a couple of slides ago, ideas about healthy nutrition. Have you found that it's, in general, better to approach it similarly for all children and all families, not differently for families where you've identified a child as overweight or obese? And I ask that question because parents worry about obesity but have trouble identifying their kids as overweight, and at the same time often resent pediatricians bringing this up. So if you can do it for all the kids in a similar way, do you see a difference there in the implementation?
So the question was related to pediatric clinical practice and whether you use a one-size-fits-all approach versus tailoring to individuals, particularly related to BMI discussions, obesity discussions, how you frame that so that parents are receptive to the information and not feeling stigmatized or upset through the discussion. So there's plenty of pediatricians in here that can also talk about this, including many more that have experience. But I would just generally say that I do think, like, if you make it a practice, so for example, for this childcare program, we did provide those reports to everyone, and we tried to use language. We didn't, for example, flag anyone as obese, because that, even like this was done many, many years ago before the literature came out talking about proper ways to talk about weight and what is receptive, what parents receive in clinical practice. And I think the literature is saying that obese is not a word that parents really like to hear. And so talking about healthy weight is also extremely important rather than talking about obesity. I do think that, while there are some approaches that maybe fit most people, I think like almost all clinical discussions, it really does need to be tailored to the individual's experiences. So for example, if we tell everyone to drink water, but individuals don't have safe drinking water in their home or worried about that, that's already a barrier. And in a clinical practice, we don't have time to go through everything, but hopefully by bringing these families back more frequently, you have time to delve further into those discussions. I hope that, is that answering the question, or do you have other thoughts?
Well, I think it does, in the sense that it's important for all families. And if you've had a chance, without spending a lot of time at understanding whether they're even interested in talking about it, you can get an idea pretty quickly about whether parents are concerned about nutrition, worried about their children's weight, but also willing to discuss the importance of healthy nutrition and healthy weight.
Yes, so I agree with you. I think that it is important, to bring this up in discussions and to understand how receptive families are. And it's just like, the stages of change model, kind of seeing, are they pre-contemplative or where can we move in the discussion? So, yes.
How juice was mentioned as a gateway to other sugar beverages. Is water a gateway to other healthy habits?
Yes, so there have been, that's a good question. So the question was, juice is considered a gateway to other beverages like sugary drinks. Is water considered a gateway to healthier beverage consumption? So there have been many studies using NHANES data that have shown that drinking water is associated with other healthful behaviors. However, I think the key question with water is whether or not you can get the substitution effect. So we do a lot of work in schools, improving the environment and educating families about why water is important. In the studies that have been done in schools so far, where they improve access, they have seen reductions in overweight. However, the two studies that were done did not find that there was a reduction in sugar-sweetened beverages, interestingly. So it's not clear if it's related to a decrease in food intake, perhaps. And in the study we're conducting right now, we are measuring all dietary intake, so we will be able to get at that a little more. But I think that is an important question, is whether the substitution is happening, because that's what you want to happen in the end. I think the soda taxes are showing that folks are switching over from these sugary beverages to water, so I think that there's promise on that front. Yes.
Comment on the use of sports beverages, the trickling down to the younger children?
So the question was related to sports drinks and how that is used among younger children. So I think sports drink is another area where there is a need for, actually it's funny, this doesn't talk about it, but I think these are lumped into the sugar-sweetened beverages because they are considered a beverage that has added sugar, or low-calorie beverage, because sometimes they use artificial or non-nutritive sweeteners in those beverages. So they are not recommended for 0 to 5-year-olds. But I do think it's, especially in this area, given the amount of physical activity that's happening among a lot of kids, sports drinks are seen as a healthier option that's needed for sports. So I think it is important to talk about that to families, to say that most kids actually are fine with just water, that they probably don't need to consume these electrolyte replacement beverages. Yes.
If obesity is not an issue in counseling with parents and so on, fresh squeezed juices like orange juice and milk as sources of vitamin B and vitamin C seem like perfectly reasonable options, but the way you frame things, you pushed water as the beverage of choice, regardless of weight. Could you comment?
Yeah, so I think the new guidelines do kind of, the kind of take-home point from the new guidelines are water and milk are the go-to beverages for kids 0 to 5. So that is generally kind of what these guidelines say, and this was really extensive work done by many organizations coming together. So I think the movement is to promote fruit consumption rather than juice, knowing that most children are consuming excessive amounts. I agree with you. I don't think that every child is exactly the same, but there is also, apart from obesity, there's also dental caries that we see as a huge problem in our clinical setting. A lot of children need to actually have general anesthesia to have them repaired in this age group and to get the cavities, filled. So I think, there's a number of health issues. I think juice is fine in moderation, but water and milk are probably the best go-to beverages on a regular basis. Any other questions? Yes.
I do believe you give us a great presentation. Actually, I have a language barrier, so I try my best to understand what you say. From my experience, I run a startup here. So for behavior change, from my experience, you try to make behavior change, make it real for the kids, for all kids, maybe for beverage, for water. So from my experience, that the best way is not to teach what they should do. It's just that to make their awareness what they are doing. So we have successfully helped the general college students get a calorie intake reduction within 9 months, almost 20%. So how can we do this? That college students, they don't care about health. They don't care about anything. They just freshman 15, right? They just want to eat what they want, drink what they want, right? But we do. We use the IoT skill to make the data real-time realization. So you just go and you just know the data. So I think maybe we can design a digital bottle, water bottle. So when you drink, you can know the exact data immediately in real time. So if you know the details data, we can switch the data. Maybe I know that children, that they have no self-control, self-discipline, right? So maybe we can switch the data maybe to a gaming, right?
Okay.
Maybe we can use a health index compatible with their classmates, right? So with their friends. So maybe it works. So I think that the best way maybe to involve all the parties, all the students together, and not to teach you don't teach what you should do. You just make your awareness what you are doing. So
Actually,
that's my point.
So I'm going to repeat that comment for everyone who's on Zoom. So basically the comment was, it's hard to educate away these health problems. I totally agree. I think it's a combination of policy, systems, and environmental approaches that make a difference, and education is just a little extra. And the other comment was regarding potentially using some incentives or gaming approach to change behavior. So an example would be like a digital water bottle that tells you when you're drinking enough or encourages you. Actually, there is a water bottle out there already like that, because someone approached me to do a study on it. It's actually has like a little cartoon character in the bottle, and once you drink a certain amount, it actually moves, and it's really expensive water bottle. So we decided not to go that way because nobody in our families that we work with could afford it. But it is a great idea. If it were effective, maybe insurers would pay for it, and then it would be more accessible to everyone. But I agree. I think that you have to make it fun for kids and exciting. It can't just be talking to them about why it's important for health to change behavior. All right, I think we're running out of time.